Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Hello, everyone. Thanks for the introduction, Sarah. Like everyone said, I'm a physiotherapist who's been working at BJC for about 6 years now, and we'll be talking about inflammatory and mechanical aspects of shoulder pain. So to start with, I'm going to start sharing my screen. We'll have a bit of a PowerPoint. All right, perfect. So now, like Sarah mentioned, I'll be starting off on talking more so about the inflammatory components of shoulder pain, talking about a few different conditions, as well as some things that Tim might be going through is going to be more along the mechanical aspects. If people have any questions, more than happy to pop them through the chat. So starting off into talking about inflammatory shoulder pain. So what is inflammatory shoulder pain? Usually it's something that's caused by our body's immune system. So it's not something that usually comes from something acute, like being involved in some sort of car accident or any sort of acute injury from a sport, although it can, but not commonly. It can often result in persistent symptoms. So things like fatigue, stiffness, fevers, all those kinds of things can be part of inflammatory shoulder pain as well as resulting in the systemic symptom side of things as well. So let's talk about some common inflammatory conditions. So up here, I put up some of the common inflammatory conditions that can typically tend to affect the shoulder. Things like rheumatoid arthritis, polymyalgia rheumatica, frozen shoulder, systemic lupus erythematosus, as well as psoriatic arthritis. Now, for the purpose of today's talk, I'll just be focusing on these first three, rheumatoid arthritis, polymyalgia rheumatica, as well as frozen shoulder. And I put in brackets there things that I might just talk about. So RA, PMR, as well as adhesive capsulitis. They're just other terms that we can use for the condition. So diving into rheumatoid arthritis first. Rheumatoid arthritis can affect many areas of the body. But for the purpose of today's talk, we're talking more about how it impacts on the shoulder. So let's talk about what rheumatoid arthritis is. It's an autoimmune condition that primarily affects different joints across the body, primarily your synovial joints. So within the shoulder, it causes inflammation around some of the fluid, the lining along the joint. So it can lead to joint damage, deformity, and pain around the shoulder. Now, the inflammation typically tends to affect both shoulders at the same time, as opposed to just something that affects one side. But like I said, it can involve other areas of the body, such as the hands and the feet, along with other areas. Now, looking into how it can tend to affect someone with rheumatoid arthritis in the shoulder, typically, and I want you to have a think of relating these to yourself, so whether or not this is something that affects you and whether or not this affects someone that you know of. But typically, it tends to come on gradually for those who come between the age of 30 to 50 years old, but it can occur at any sort of age as well. Now, it typically presents in multiple joints, but the shoulder can often be involved as well. But in the shoulder pain, it typically tends to present with deep, persistent pain, as well as affecting other joints. There will be joint swelling and warmth at times. So when you go to compare, along with other areas of your body, you might find that it might be a bit warmer compared to other areas when touching. And you'll find that the pain in rheumatoid arthritis tends to develop a bit more. When I say gradual, we're talking more along the weeks or months side of things, as opposed to something that occurs instantly. Now, you'll find that typically it will have morning stiffness, so something that lasts around more than an hour will be classified as having some form of inflammatory component to it, as opposed to something that typically resolves within 5 or 10 minutes. And when I was talking about those systemic symptoms earlier, so things like your fever, your fatigue, your malaise or paleness, as well as unexplained weight loss, people might display some of these symptoms as well. Now, The dangers of some of these things is that if inflammatory conditions are left untreated, they can often cause deformities within our joints if left untreated. I'll go into some of the treatment options for a lot of these inflammatory conditions later on in my section, but important to try to get the diagnosis early, which is part of why we're doing these talks, so that people can recognize these symptoms, recognize the pathways to go for help, as well as what people can do in order to, once they recognize that they have these symptoms, in order to try to get the correct treatment and not let it get to the point where it's causing any of those joint deformities. Looking onto another condition that typically tends to affect the shoulder, something called polymyalgia rheumatica, or PMR. So this differs a little bit compared to rheumatoid arthritis. It's an inflammatory disorder that typically tends to affect both the shoulders as well as the hips. Some of the muscles and tendons tend to get affected in this as well. So muscles, tendons, bursa, a lot of these areas can be affected, as opposed to something like rheumatoid arthritis. Within rheumatoid arthritis, like I said, it tends to affect the joint and it attacks the synovial lining around the joint, whereas in PMR, it doesn't really affect those types of areas and affects just the muscles and the tendons. Now, with polymyalgia rheumatica, it typically tends to develop in those between the ages of, within those over the age of 50, but can also occur in those within this 50 to 60 range. But it's very, very rare to see it happening in those under the age of 50. Pain is often quite intense and often presents as a bit more of a sudden onset compared to rheumatoid arthritis. So this one can develop in the space of days or weeks. As I mentioned, it tends to affect both the hips and the shoulders as well, as opposed to more just being on the one side. And it will worsen with periods of inactivity. Now, pains with this, people will experience stiffness in the mornings. But after this, people tend to feel better once they get moving in the morning. So things like moving around, typically more along the lines of gentle movement, but people will feel better once they get moving. The duration of PMR symptoms can sometimes last from weeks to months and can wax and wane with periods of exacerbation as well. Now, the pain that people describe when people have PMR is actually quite similar to those with rheumatoid arthritis, where they describe it as a deep aching sort of pain. But typically it affects the muscles and tendons around the shoulder as opposed to the joint. People will experience a bit of a loss in how well they can move the shoulder, and they'll experience a lot of issues with trying to reach anywhere above their head when the symptoms are tending to be a bit more progressed. But sometimes as the day goes on, they find that they might loosen up and they will feel a bit better. Since with PMR, it doesn't really tend to affect the joint, there isn't really any joint swelling or warmth associated with this type of condition. Now, referring into the systemic symptoms, people can tend to have things like fevers, fatigue, weight loss, as well as low-grade inflammation. If people were to get a blood test, there are inflammatory markers within a blood test that a GP or a rheumatologist might ask you to complete, which I'll go into in a bit more detail, but the people will tend to have elevated inflammatory markers on a blood test as well. But unlike rheumatoid arthritis, like I said, since it doesn't affect the joint, it doesn't really tend to cause joint deformities or joint damage like rheumatoid arthritis does. However, if left untreated, this has other implications as well, such as things that might affect other areas of the body, such as the eyes. Now, going on to the next type of condition that we may come across with regards to shoulder pain is along the lines of frozen shoulders. Unfortunately, with frozen shoulder, like I mentioned here, we don't really know enough about frozen shoulder to know as to what might be causing frozen shoulder. But What frozen shoulder is, it's related to the inflammation of the shoulder capsule. So this is something that encapsulates the shoulder joint and surrounds and supports the shoulder joint and stabilizes it along with other things. Now, when there's inflammation of this capsule around the joint, it can lead to things like adhesions as well as thickening. It happens a lot to those who have prolonged periods of immobilization of the shoulder. So imagine someone who's been in a sling after having suffered from a fracture in the elbow or a collarbone fracture. They may find themselves in a sling for 6 to 8 weeks. And that might be enough to try, and that might be enough to develop something like a frozen shoulder, which is why after any sort of period of immobilization, it's always important to try and get the shoulder moving as early as possible to minimize the risks of developing something like this. Interestingly, there are other areas that might increase the risk of people developing frozen shoulder. We looked at studies involved with people with thyroid issues, and they found that particularly people with hyperthyroidism, so an overactive thyroid, they tended to be 2 to 4 times at more risk of developing a frozen shoulder when compared to the normal population. And those with diabetes, people with diabetes were shown to be at 5 times more risk when compared to the normal population. The general population, the prevalence of something like frozen shoulder might sit between 2 to 5% when compared to, say, for example, with diabetes, that might come up to 10 to 20%, which is about 1 in 10 to 1 in 5 people with diabetes might end up with a frozen shoulder. Now, talking a little bit more about the symptoms of frozen shoulder, pain and stiffness tends to develop more slowly with a progressive loss in the shoulder range of motion. Now, unlike the other 2 conditions like rheumatoid arthritis and polymyalgia rheumatica, this is something that typically just tends to affect one side at a time. However, it is important to note that when looking at studies and when looking at different articles that might look at people's risk of developing a frozen shoulder on the opposite side, there is an increased risk of developing frozen shoulder in the opposite side at another point in time. But it's hard to say as to whether or not this is truly the case, as a lot of those people do have things like the diabetes as well as thyroid issues as well. It's common more along the lines of those between the 40 to 60-year-old group, but once again can happen amongst people of all ages. And unfortunately, with something like frozen shoulder, can be quite debilitating and can last 1 to 3 years. Now, you can see here in the diagram at the bottom, the full cycle typically tends to divide itself into 3 stages, known as the freezing stage, the frozen stage, as well as the thawing phase. Now, in the freezing stage, this typically tends to be when pain is at its worst. People have lots of trouble with sleeping. People have trouble with moving their shoulder around in all sorts of different ranges of motion, and things will be really, really horrible. Typically, what people will find is that if we can manage to get onto this early and trying to get things like an injection or some sort of treatment into the shoulder joint early, it can help a lot with relieving that pain and trying to reduce the timeframes it takes for recovery. Otherwise, sometimes it can take a lot longer, more towards a 2 to 3 year side of things. Once things then develop into move forwards into the frozen stage, pain starts to slowly diminish, but it's more about the loss in range of motion of the shoulder that people then struggle with. So people will still have trouble trying to reach overhead, but luckily in this stage, pain will start to diminish and people will then be able to start to adapt to movements. However, people might find that because they're adapting to different sorts of motions, that they're finding that they're compensating through other different areas of the body. They might be lifting their shoulder every time they try to reach for their cupboard overhead, or doing something similar, and that might cause other problems as well. So then moving into the 3rd stage, the thawing phase, this is when the joint starts to loosen up. People start to get less stiff in the joint and they're able to move around with much more comfort, and their range of motion will then start to return back to what it was. Now, Good thing with frozen shoulder, people don't tend to develop any sort of systemic symptoms like your fevers or your fatigue as much. Symptoms are very much localized just to the shoulder joint, without really affecting too many other areas of the body. Now, we will move into more of the diagnostic process side of things. So things that might help people to understand as to what to do, or when you might suspect that you might have something like an inflammatory shoulder condition. Obviously, one of the things is trying to get on top of it early and trying to either engage with your rheumatologist or your rheumatologist, or if you have one, or your GP, or if you have a physiotherapist or exercise physiologist or some sort of health professional, through an effective history taking and with subjective questions and objective assessments, we'll be able to get a bit of an idea as to whether or not you might be suspicious of any of these conditions. Now, if we're suspicious of these conditions, we might refer you to a doctor, whether or not they be a GP or a specialist, to get something like a blood test. In one of my previous slides, I alluded to things like having a look for inflammation in our bloods. More specifically, an example of some of these, one is called your CRP and another is called your ESR. These are both markers of inflammation that sit within our blood. And for those with inflammation in our body, these can be elevated when looking at our blood tests. However, it is important to note that not necessarily, not in all cases, do these have to be elevated for us to have an inflammatory shoulder condition. But it is just one piece of the puzzle that might help to improve the likelihood of getting the right diagnosis. Another thing that we can consider is things like imaging, so whether or not that be an X-ray, an ultrasound, or an MRI, to detect any sort of swelling, any sort of fluid and joint damage that might have already occurred in the joint. Now, once again, this will vary depending on the condition. So, for example, things like your frozen shoulder, you might want to get a scan early to try and see if there are if there's any scarring of the capsule around the shoulder. But for other conditions, sometimes a blood test or a good history is enough. You may not necessarily need a scan as well, but that will be dependent on the health practitioner that's helping to look after you. But once again, need to make sure that early diagnosis is always the key. If we can get onto your symptoms early, and if we can get you onto the right treatment pathway early, your prognosis, how long you take to recover, will often be much quicker. You'll be in less pain much quicker, and it'll lead to much less risk of things like joint damage from occurring. Now, moving on to the treatment side of things, we'll talk a bit more about the medical side of things first. So with the medical side of things, our main aim is to try and reduce inflammation, manage symptoms, as well as prevent joint damage from occurring. On top of trying to diagnose it early, other things that we can do from a medication perspective, and this will be more of a discussion between yourself as well as your GP and your rheumatologist. But these can be things like your non-steroidal anti-inflammatory drugs, or your NSAIDs. Some people, depending on the disease, might be asked to take something like a DMARD, which is a disease-modifying anti-rheumatic drug. Other things will be like corticosteroids, whether or not they be injections or tablets, as well as if people are eligible and if it's suitable depending on the disease, people might be asked to start something like biologics. Biologics are something that just target specific part of the immune system, and typically for conditions such as rheumatoid arthritis, if they're not responding well to other conventional strategies. Now, apart from a medical approach, that's just one facet of things that will help to address the inflammation side of things. But a lot of research has shown that not just looking at although the medical side is important to try to get inflammation under control, there's also the non-medical approach and trying to look at the conservative side of things. And if you were to combine both the medication along with the conservative side of things as well, that people always end up with better results when just doing either medicine alone or just the conservative side of things alone. Usually having two in conjunction with each other will provide the best outcomes. So going into the conservative side of things, Main aim behind the conservative side of things is to try and improve mobility and strength through things like exercise and physical activity. Maybe I'm a bit biased as a physiotherapist, but I think a lot of this can be guided through by seeing someone for help, whether or not this be an exercise physiologist or a physiotherapist, to help provide a tailored program that suits you, as opposed to something that might be a bit more generalized. Because let's face it, there's not many things that's one size fits all with regards to exercise. You'll find a lot of these conditions, and Tim will go into a bit more detail with relation to this, but a lot of these inflammatory conditions will also present with some form of mechanical components of the pain as well. If I were to just take an example again with frozen shoulder, because people will have that loss in range of motion, people will try to do all sorts of other things with the rest of the body. Their neck might be shifting, their back might be trying to hunch over to try to get us to produce the movement, since the shoulder isn't able to do the movement. And that might end up with secondary mechanical components as well. And Tim will go through things that we can do to help with that. Things like ice and heat application can really help. Ice is typically more so for the acute side of things, the acute inflammation and helping with numbing out any sort of pain. But typically, I find that heat with stiffness is always a really, really good thing. A lot of my patients will find that having a really hot shower in the morning can help a lot to help relieve their symptoms. And then last of all, looking at things like lifestyle modifications. And you'll notice that these points that I've listed here, they're just general tips to try and stay healthy. But these are all tips as well, because simply by staying healthy, they can help to reduce inflammation in our body. So things like having an anti-inflammatory diet. So this might be foods rich in omega-3, fatty acids, antioxidants, and fiber, and trying to avoid things like your alcohol, your sugary foods, and processed foods as well. Making sure you get good sleep. So good 8 hours sleep, sleeping early, and waking up early as well. Making sure we can manage our mental health and stress. So people will find that a lot of the times this can exacerbate and increase levels of inflammation in our body as well, not just with how we feel, but even if we were to get a blood test, this can show on a blood test that we have raised inflammatory markers as well. Physical activity, so doing a bit of low, gentle, regular physical exercise can help. As well as things like smoking, reducing smoking and alcohol intake can really help manage stress, manage to reduce inflammation as well. Now, I'm going to take a little bit of a pause here to answer any questions that I might have with relation to the inflammatory side of things before handing it over to Tim, who will be talking more about the mechanical side of things.
Good one, Jackson. Tim's done you a favor and answered some questions along the way, which
Perfect,
is good.
Tim.
But I guess maybe to summarize, because there's definitely a lot to take in there, which is great. The key for the inflammatory stuff is really to try and get that sorted early if you can.
Yes. Yeah.
And so we haven't gone into the mechanical stuff yet. But even just from hearing Jackson talk tonight, if you're concerned, if you're thinking, oh, you know what, some of those things sound like me, definitely going and talking to someone, if you haven't already, is a good step to then get the ball rolling, because definitely for the inflammatory side of things, the only person who can really then help you access some of those treatments is a rheumatologist and maybe a GP. So definitely a physio and exercise physiologist. We can't prescribe drugs. We can't do that part of it. So for any of these conditions that Jackson's mentioned, you definitely need some help in getting that correct diagnosis and then opening up the treatment options. So, okay, maybe we've got time for one question, because I want to make sure you hear from Tim, and then we'll come back to any question. Oh, there's some good ones coming in now. But thanks, Tim, you've answered some. We've talked about gardening. I'm sure Tim's going to touch on things like gardening. So I won't answer that now. But maybe this one, Jackson, this is one of the first. Is it possible for people with a shoulder issue to get referred pain down the arm, whether it's inflammatory or mechanical? In your experience, have you found that to be a possible phenomenon?
Absolutely. People with shoulder pain, whether it be inflammatory or mechanical, often often present with referred pain that occurs down the arm. What I find most commonly people will complain about is more pain that typically comes down the upper arm, although this can happen all the way down in specific parts of the arm as well. And most of the time, it's not problems like at the areas and sites of the pain itself, and they might be more involved with areas that sit inside the shoulder girdle itself. So treatment might not actually look at targeting those areas that are painful, but more looking a bit more centrally. But yes, very commonly, most people, I would say, actually do have referred pain coming down the arm.
Yeah, that's
excellent question.
So tricky, because sometimes where the issue is actually stemming from is not the area that you're experiencing pain. So that can make the whole thing even more confusing and tricky. But great question. Jackson, I'll try this one. This is a great question, which I'll read out and then maybe I'll put my 2 cents in and then you can go. So Claudia's asked, when a patient comes into the clinic, what is your process? So I think the first thing is, what's your process as a physiotherapist? And yes, it might be across sessions or within how you ask questions and what you assess for you to know that, yes, this is definitely polymyalgia rheumatica, as it looks like, and it can echo other conditions. So I guess what I'll mention here is that as a physiotherapist, and even so myself as an exercise physiologist, we can't diagnose you 100%. Even if we think it's the case, we can't. It's not really within our scope of practice to do that. But I'll let Jackson take you through. If someone presented with shoulder pain, and let's say it's like, I've just got this sore shoulder, or maybe I've got 2 sore shoulders, I don't know what's going on. Maybe Jackson explain what you would kind of go through briefly, because I know Tim's going to go through his stuff too, and what your steps would be as a physiotherapist if you suspected polymyalgia rheumatica, because I think it's a great question.
Yeah, really good question, Claudia. As you mentioned, it can look like so many other conditions as well. And sometimes it is a little bit of a process of elimination. So, for example, if I was to think that it might be polymyalgia rheumatica, I might be eliminating other things. So, for example, is it a mechanical thing? I might be asking questions to see if there was any particular thing that might have caused it, or whether or not they changed what they did in the last few weeks that might have caused their pain. I'd be a lot more suspicious if they were having hip pains at the same time, or if both shoulders were sore without any really clear reason. So a lot of it is like looking at the history. So it's trying to see whether or not their history tends to match with your current symptoms. So say, for example, if it's someone who hasn't really been, who's been fairly healthy, and there's really been no reason for someone to just out of the blue suddenly develop these pain in both your shoulders and start to develop these intense stiffnesses in the hips as well, then I would be trying to liaise with their GP. And if they haven't seen a rheumatologist, I'd be talking to the GP to see whether or not you'd be able to organize a referral to see the rheumatologist as well. As Sarah mentioned, as a physiotherapist, unfortunately, not within my scope to diagnose this condition, but send it to someone who's a bit more appropriate. So things like a GP as well as your rheumatologist to help get the diagnosis right and then get you started on the treatment pathways for that.
Thanks, Jackson. So yeah, a lot of it is the questions we ask, the history, and of course, a lot of the time you'll know that as well. But having someone help you tease it out and look back at things can be very helpful. And then specific assessments. So then definitely physios and EPs will do different tests to look at the shoulder and how it's moving, and then be able to compare left and right as well, because that can be very helpful in coming up with a diagnosis. But definitely, and we're very lucky at BJC because we work with rheumatologists and we've learned a lot about these conditions over the years. If we're suspicious, we know we've got people we can ask and then guide you with, getting a referral and maybe being checked out.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.